me just one moment before we start.
Bisa manggil orang-orang untuk masuk nggak, terutama yang TPL. Beberapa TPL yang di sini, mereka masuk ke ruangan, jadi nggak bisa attend. Jadi mungkin PPDS deh, biar agak banyak sedikit.
Baik, Prof.
Telepon satu orang gitu loh.
Baik, Prof.
Nanti Dr. John dia akan presentasinya, dia udah rekam, recorded katanya, udah direkam videonya, nanti dia akan play, setelah selesai baru kita diskusi, Prof. Karena dia udah persiapkan katanya.
Nanti saya official ngomong sebentar ya, Bob.
Iya,
Buat
Prof. Iya, Prof.
dibaca.
Nanti Prof jadi ngasih ini juga greetings.
Would it be okay if I play my slide deck real quick and just see if you can hear the audio and see the visual?
Yes, yeah, sure. You can try to share the video.
Wait.
Ini bawa ini, Pak. Bawa... Ya, nggak dibawa lagi. Tas bodoh. Kamu pakai? Oh, enggak usah deh. Ada. Ya, ada headset di kamu. Headset. Bob, bicara, Bob.
Iya, Prof.
Oke. Enggak, saya baru nyoba headset.
Oh, jam berapa Prof mulai ini bicara?
Saya masuknya session jam berapa sih? 9.30.
9.30.
Sekarang masih ada yang bicara dari USA, terus ada Dokter Widi bicara. Nggak kedengeran dia ngetes. Hah? Kita ngetes video.
Belum,
Halo, Dokter.
belum lagi mau di-share.
Oh gitu.
Ya.
Kamu
Lagi
mau
nyoba.
ngambil itu saya ada di kamar, kotak mau diambil. Handoko ngambil. Ini saya.
Oh, Prof lebih enak pakai punya.
Bukan, sama aja, cuma biar nggak berisik aja kamu.
Saya nggak mau bantu.
Enggak, itu nggak mau dengerin Dokter Widi itu nanti ngaco lagi tentang apa?
Dokter Widya gitu.
Iya, kan tentang itu apa namanya akustik melanoma.
Ya.
Untung dia nggak bicara tentang sorry Bob. Yang ikut Bob cuma 200. Udah gitu
ya?
yang paling banyak onkologi radiasi. Cuma sayang kita nggak kasih informasi hari ini pakai baju. Kalau hari ini pakai baju, udah banyak banget orang kita di sini.
Oh, neuronya nggak banyak, Prof.
Nero berapa sih kemarin komposisinya neronya berapa?
Oh, neuro kan banyak.
Iya. Tapi nggak banyak banget di atas kita kan, cuma beberapa di atas kita.
Kota 400.
Oh.
Kalau
nggak salah mereka nggak banyak banget deh. Bangsa 30-an gitu.
Total 210.
Iya. Mahal kali.
Mahal ya.
Hah? Bob ini suaranya dia belum keluar loh. Dokter
Iya, ini Lagi nyoba, Prof. Dia lagi
John,
Yes.
your voice is not yet.
Yeah, it's not playing from
Oh, it's not playing. Okay. Okay. You
Yeah, I
will
might
play
have
the
to
recorded, right? Okay.
I might have to do something different.
Yeah.
Give me one
Oh.
moment. Oh, wait a minute. Here we go. This might work. Let's try that. Could you hear that?
no.
No
Just
sound from the video.
No sound from the video.
Or
Well, if nothing else, I'll just talk. That would work as well. Let me see if
or
there's a way to.
perhaps,
Let me see if
or
there's a
you
way
could
to
send it to
share.
us. You can send the video to us, and we'll try to play it.
I wonder if. Might do that. Do y'all have a Dropbox link or a way I could share it?
hmm.
I could do that real fast. Hold on 1 minute. Actually, you know what? I'll just do it from scratch. I'll just go from my slides. Except
So you
now
will
it's
Okay.
talk directly.
except now it's playing my audio, so I am hearing myself talk.
But you've clicked the share audio when you share screen.
I've got share screen. I don't
When
know if
you
there's a way to share audio.
Yes, if when you click the share screen button and the
Here's-
bottom of the window, there's like an audio option.
See if this works.
Okay.
Germ cell tumors are a histologically diverse. Could you hear that?
Yes, yes.
You could? Okay.
Yes.
Okay, great. Excellent.
So,
So
okay.
Okay.
would it be beneficial to
Yeah,
I'm
okay.
happy to do it from the video, and then I'll be here and happy to answer any questions on the back end, but it's a little bit more rehearsed on the video. If that's okay.
So we can open this session, Dr. John.
Great.
Ya. Udah
Okay.
tadi kedengeran.
Okay, hello everyone. Good morning here in Indonesia, and also good afternoon there in Memphis, and welcome to our TPL series for webinar. The topic for today is radiotherapy for pediatric CNS germ cell tumor by Dr. John Lucas. So Dr. John Lucas is from St. Jude Children's Research Hospital. So before we get started, I would like to take a moment to thank IROS, Indonesian Radiation Oncology Society, specifically the division of TPL. TPL is a division of subspecialty, consists of thorax, pediatric, and lymphomusculoskeletal for hosting this webinar. So I would like to welcome Professor Soehartati. Professor Soehartati is our past president of IROS, and currently she's a chairperson of this division of TPL group. So, Prof. Tati.
Yes, thank you very much, Dr. Bobby. And first of all, of course, I would like to thank again to Dr. John Lucas for being with us and your willingness to share your knowledge about the multimodality care in intracranial germ tumor with us. And as it is already mentioned by Dr. Bobby, that we in IROS just started last year to divide it this our focus on three subdivisions. The first is about head and neck and brain, CNS, and so. And we are in the middle. In the middle is we divided in thorax and pediatric lymphomusculoskeletal.
and the other is about the urogynecology. So we have a routine upgrading our knowledge and skill about our region, that we have to increase the knowledge. That's why we are here now. Our member is not there to many, since that you know that the IROS member is not yet more than 150, and not all the member of IROS is already namely as a consultant or subspecialist. That's the reason why our number of the participants for this meeting is also not too high, since that for the TPL, the number of TPM member is around 30. But so we know that there are also from other subspecialists in radiation oncology coming in this special event for today. So again, thank you very much. As we know that to treat pediatric in oncology is not like to treat a small adult person, but it is, we have to have a special attention for the kids who are not really happy to have a cancer patient. So for that reason, we are very thankful again to Dr. John Lucas to be here with us. And hopefully this meeting or this discussion will give a more benefit for us as well as to our patients. Thank you very much. Prof.
Thank you,
Thank
Prof.
you so much.
Thank you,
Yeah,
Prof.
thanks.
So,
Dok, foto dulu ya.
oh yeah, okay. I think before we started the session, we can take a picture together. So I would like to ask all the participants here to open the video, and then we will take a moment of pictures, just a little bit. So I'm sorry, John. Dr. John, can you stop this? Stop the share screen first, and then thank you very much.
Yeah.
Oh, Dr. Dika.
Okay. Yes. Dear respected Prof and Doctor, my name is Dika from Aurora, Indonesian Radiation Oncology Resident Association. First, I would like to thank you for joining our meeting today. Now I will assist you in taking our group photos. The picture will be taken twice. So kindly turn on your camera and please hold still for a brief second so we can get a clearer picture. Okay. In my page, there is 3 pages of this meeting. So we can. So please hold a brief second. Okay. 1, 2, 3. Smile, cheese. Okay, please hold still. Okay, one more. 1, 2, 3, smile, cheese. Okay, it's done. Back to you, Dr. Bobby.
Okay, thank you, Dr. Dika. Okay, thank you, Dr. John. You can share the screen.
Great.
And while Dr. John is sharing his presentation, I would like to briefly introduce Dr. John Lucas. Dr. John Lucas is a radiation oncologist, a associate professor from St. Jude Research Hospital with main interest in pediatric cancer. He has published extensively on the topic of radiotherapy for pediatric cancer, and he's leading expert in this field. In this webinar, Dr. Lucas will discuss the latest advances in radiotherapy for pediatric CNS germ cells tumor. He will also provide an overview of the treatment options available and the factors to consider when choosing a treatment plan. Please join me in welcoming Dr. John.
Thank you so much for that great introduction, and it's great to see all of you and participate in this event. Of note, I think this is a perfect time to give this kind of talk because there's been a lot of recent developments and updates, and so hopefully we'll be able to highlight some of that after we go through just some basics related to the disease. So I've pre-recorded part of it, but I'll be here the entire time, of course. And then we should have plenty of time for questions, I believe, on the back end.
Yeah.
Hello, my name is John Lucas, and thank you
Yes.
to the
Go ahead.
organizers for the opportunity to present multimodality care and intracranial germ cell tumors. Germ cell tumors are a histologically diverse collection of tumors originating predominantly in the suprasellar and pineal region, although involvement of ectopic sites, including the basal ganglia, are possible. The age distribution ranges widely from teenage years to early adulthood, and the clinical presentations can be diverse and fascinating. Patients with pineal tumors most often present with raised intracranial pressure secondary to cerebral aqueduct obstruction and/or Perhimpunan syndrome, usually due to compression or invasion of the tectal plate. Patients with suprasellar tumors may present with visual disturbances, endocrine dysfunction, and precocious or delayed puberty, the combination of which is known as the suprasellar triad. Patients with bifocal tumors may present with any combination of the above. Patients with pineal lesions that present with diabetes insipidus but no identifiable suprasellar lesion should be thoroughly evaluated for the potential of occult multifocal tumor. Patients with tumor in ectopic sites may have unique symptoms such as mental or motor deterioration. At presentation, if there is suspicion for an intracranial germ cell tumor, a cautious, thoughtful approach will result in improved staging and subsequent treatment. Laboratory workup may reveal elevated germ cell tumor markers, including beta-HCG or AFP, and this may guide the surgeon away from overly aggressive surgical interventions once the neuroaxis imaging has been reviewed at presentation. Following this review, immediate attention must be placed on the management of hydrocephalus and any other neurologic symptoms. The management of initial hydrocephalus may also allow for concurrent staging evaluations if the CSF is obtained prior to any other procedures, and if endoscopic approaches are used, usually the tumor can be visualized and a histopathologic diagnosis may be obtained at the same time of management of the hydrocephalus. Following these procedures, workup of serum and CSF markers will usually provide additional information on the likely subtype of intracranial germ cell tumor. A wide variety of staging or workup evaluations have been proposed on prior trials, and I've summarized a few of those trial criteria here for your reference. These are accumulated from the COG, SFOP, SIOP, and MAKEI studies. Please take a moment to note the presence or absence of various thresholds and requirements for biopsy. Early neuroendoscopic and ventriculoscopic intervention can provide vital diagnostic information, as well as facilitate a pathway forward towards alleviating hydrocephalus. CSF cytology and markers can be collected at the time of ventriculoscopy if obtained prior to other procedures and biopsy. Otherwise, lumbar puncture may be used to obtain sufficient markers in cytology. Visual inspection of the ventricular surfaces during ventriculoscopy may reveal ventricular stutting, which is not readily apparent on MRI, but may be relevant to radiation planning. In general, endoscopic third ventriculoscopy may be the preferred path over VP shunt or for relief of hydrocephalus. In the adjacent figure, you can see an example of papilledema and hydrocephalus pre-shunt and the resultant relief of pressure and the ensuing flow voids across the ETV path indicating ETV function. The flow void is indicated with black arrows in panel B. Germ cell tumor patients who have relief of their hydrocephalus using a VP shunt are at risk for peritoneal metastasis, and as a result, ETV is preferred. Over the last several years, a great effort has been made to standardize the imaging and response evaluation workup for intracranial germ cell tumors, and I've listed the recommended pre-contrast, post-contrast, and spinal imaging recommendations put forth by the recent consensus group report. Given that response definitions vary, I've referenced Marina et al. At the bottom of the slide. Of note, marker-positive germ cell tumors that have obtained a CR during initial therapy still require surveillance imaging, as a proportion may still relapse without marker elevation. I've previously mentioned the diverse list of subtypes which constitute the diagnosis of an intracranial germ cell tumor, but here in the summary figure by Nakamura et al., we see each subtype with the corresponding radiologic, histologic, and serum and CSF marker profile findings. As you can see, the imaging appearance varies widely, but in general includes a mixed solid and cystic appearance with variable regions of enhancement and surrounding edema. Tumor markers such as beta-HCG and AFP aid diagnosis and are recommended to be obtained within the serum and CSF at diagnosis. The histologic appearance is often distinct to each subtype, but discordance with markers and subsequent histology is well described, such that more and more standard of practice guidelines recommend that biopsy be completed to avoid under or over-treating patients. Serum or CSF markers play a vital role in diagnosis, and evaluation is not 100% specific with regard to their profile. For instance, historical biases dictated that bifocal germ cell tumors were uniquely purely germinoma, but this has recently been dispelled, such that it's now recognized that as many as 25 to 30% of cases with bifocal disease may be mixed germ cell tumors. Here, I've incorporated some additional pictures of imaging characteristics across CT and MRI modalities for germinoma and non-germinomatous germ cell tumors for your reference. While most patients present with disease in the pineal and supracellular location, other sites are possible, and in this slide I've shown some common locations for ectopic germ cell tumors, including the basal ganglia, optic nerves, septum, and corpus callosum. Basal ganglia involvement has recently been rigorously characterized in a systematic fashion, such that types 1 through 4 are now defined. These imaging findings are often difficult to discern due to the varied extent, and patients may be asymptomatic at presentation or in extreme cases present with symptoms as severe as hemiparesis. Patients with optic nerve germinoma have been described, and of note, some of these have been reported to spontaneously regress without treatment, although standard of care dictates that these regions be included in the radiotherapy field portal during definitive management. Patients with callosal or septal involvement may present with psychosocial and behavioral disturbances and may have difficult to manage hydrocephalus. Brainstem involvement, while rarely reported, may result in subtle symptoms at diagnosis or more pronounced neurologic deficits. Before we comment on further pertinent clinical features in the diagnosis and management of germ cell tumors, I'd like to spend some time briefly on the origin of germ cell tumors and how our recent understanding of their molecular features is rapidly changing. Work by Fukushima et al. Has shown us that germ cell tumors develop from migrating pluripotent primordial germ cells. In fact, the differential components which make up a mixed germ cell tumor often share identical mutations but appear to have distinct methylation profiles. Existing literature suggests that intracranial germ cell tumors develop from a combined genetic and epigenetic mechanism from a common ancestral cell. The precise origin for each subtype of CNS germ cell tumors remains to be seen, as inferential findings will need to be experimentally investigated using in vitro and in vivo germ cell tumor models. Here, in this paper by the International Germ Cell Tumor Study Group, they've completed a comprehensive molecular profiling of all subsets of intracranial germ cell tumors and found that KIT alterations are present in 1 out of every 3 cases. Additional MAP kinase pathway alterations and PI3 kinase pathway alterations are present in as much as 50 and 10% of cases respectively. These findings suggest a potential pathway forward towards precision medicine, which may be evaluated first in relapse studies. Germ cell tumors vary widely in their prognosis, with a 5-year overall survival rate which varies according to their histologic type, but is approximately 90 to 95% for pure germinomas. The prognosis of non-germinomatous germ cell tumors has improved substantially over decades, with recent 5-year progression-free survival estimates of greater than 70%. I've listed some of the relevant prognostic factors identified from prior studies in the slide below for germinoma and non-germinomatous germ cell tumors. Given the favorable prognosis for most intracranial germ cell tumors, they are considered somewhat of an exemplar for childhood cancer treatment-related late effects. Patients may develop or present with endocrine deficiency, neurocognitive injury, hearing loss, visual disruption, psychosocial or behavioral disturbances, and may be at risk for subsequent cancers later in life. I'd now like to review the therapeutic approaches which have been used for intracranial germ cell tumors. I'll focus on several key studies and note how they've informed our current clinical practice. I will also provide some perspective on their application and finally offer up some comments for their developing avenues for future treatment. Briefly, I think it's important to remember the historical perspective on the management of tumors in challenging locations like the pineal and suprasellar region. Neurosurgical techniques historically were much more risky, such that biopsy was less favored, and radiotherapy was often used as a diagnostic tool when the germ cell tumor subtype was not known. If the lesion responded, it was assessed to be a germinoma, and definitive radiotherapy would proceed. If it didn't respond, further management and evaluation could be considered. Thankfully, this is no longer the case, and surgical techniques have improved dramatically, such that we are able to provide an adequate histopathologic diagnosis in the vast majority of cases. As I noted before, surgically addressing pineal and suprasellar location tumors has been quite challenging before the adoption of endoscopic techniques. Even today, some non-germinomatous germ cell tumor cases pose a substantial challenge to even the most experienced surgeon. Given these risks, the role of surgery has been relegated to initial management of hydrocephalus, obtaining tissue, and potentially addressing tumor in situations of residual mass following therapy completion in non-germinomatous germ cell tumors. It's important to point out here that there is no proven therapeutic beneficial effect of surgery in pure germinoma. More specifically, surgery is more routinely employed in non-germinomatous germ cell tumors, and we frequently see the need in cases of growing teratoma syndrome, which may occur in as much as 1 out of every 5 cases. Second-look surgery has been employed and has shown a substantial improvement in event-free survival on protocols like ACNS 0122. And finally, while rare, mature teratomas with no immature element are managed definitively with surgery, and this is considered curative such that no adjuvant therapy is required. I'd now like to spend a few moments on the evolution of radiotherapy field design in intracranial germ cell tumors. Historically, whole brain radiotherapy and/or CSI was used in the initial management of this disease back in the 70s and 80s. Currently, the application of radiotherapy for germ cell tumors is risk stratified based on histologic diagnosis, extent of disease, and clinical risk. Of note, there are still some areas of uncertainty in radiotherapy field design, specifically in the area of localized basal ganglia germ cell tumors and non-germinomatous germ cell tumors, which are being evaluated in current clinical trials. I previously noted some of the prognostic factors for germinoma and non-germinomatous germ cell tumors, but here I've listed the characteristic risk groupings which have been used on prior trials. Of note, current trials have moved towards a risk and response-based strategy in each tumor subtype. Also of note is that there's some controversy with regards to the role of AFP, as AFP levels weren't statistically significant for event-free survival or overall survival on ACNS 0122, but it did appear to be clinically significant. This is used as a risk stratification factor in CNS GCT2, as well as age less than or greater than 6 years. In this slide, I've summarized the evolution of multimodality therapy for germinoma. Each approach from the last several decades is listed with a respective treatment approach and associated clinical trial. Briefly, I'd like to touch on several points which have emerged from large retrospective series or prospective trials discussed here. Specifically, definitive radiotherapy is still the preferred treatment approach for metastatic germinoma using CSI, as the addition of chemotherapy does not appear to improve outcomes. Chemotherapy alone strategies, like that employed by the early international germ cell tumor group studies, is strongly discouraged, given that as much as 60% will relapse. Whole ventricular radiotherapy is often the preferred radiotherapy field, unless there are uncertainties about or incomplete staging at diagnosis. The current standard of practice is based on the use of induction chemotherapy, which now facilitates response-based dosing, which has the potential to reduce the long-term neurocognitive and neuroendocrine side effects of higher doses of whole ventricular and focal radiotherapy. This figure, generated from the supplementary data from ACNS 1123, shows the estimated IQ, attention concentration, and processing speed from the experimental and control arms of the study. As you can see, there were no detected differences in attention, concentration, or processing speed between the two arms, but there was a trend toward improved estimated IQ at 30 months with reduced dose whole ventricular radiotherapy. Given that equivalent disease control was observed with reduced whole ventricular radiotherapy, this is now the preferred approach and pathway forward for further dose reduction and mitigation of treatment-related late effects in pure germinomas. There are still a number of unanswered questions with regard to the multimodality approach for germinoma. In this figure from a paper by Graham et al., we can see the diversity of field extent for patients with localized basal ganglia germ cell tumors. While an interaction was noted with systemic therapy, which makes this evaluation challenging, it's not clear that larger fields confer an improved event-free or overall survival for this disease. Of note, the role of whole ventricular radiotherapy in localized basal ganglia germ cell tumors is being evaluated in CHN IGCT 001. In the paper I reviewed previously by Fukushima et al., which characterized the molecular landscape of germ cell tumors, it was noted that 1 out of every 3 germ cell tumors has a KIT alteration. And so this target appears particularly attractive for cases of inappropriate response with residual malignant components or relapse disease. This figure from that paper shows the spectrum of alterations in KIT. Of note, many of these alterations are either predicted to or have been shown to be sensitive to existing targeted therapies like those listed below. At present, outcomes following inhibition of KIT in germ cell tumor studies have had varied results, and so well-designed, large studies evaluating these agents will be vital moving forward. Recent and upcoming germinoma studies in North America, Asia, and Europe provide a window into what the likely coming standards for therapy are likely to include. The North American plans for trials continue with a similar chemotherapy backbone and employ a response-stratified approach toward further dose reduction in germinoma. 2 new subpopulations will be added in the coming study, metastatic cases and basal ganglia or ectopic cases. Each of these subpopulations will have different corresponding fields but similar phase 1 and 2 dosing schemas based on response to systemic therapy. In Asia, the results of SMC G18 suggest the lowest dose on record for patients with a favorable response to induction chemotherapy of 21.6. Few failures have been noted with this treatment paradigm. The next study, conducted by the JCCG in GCT 2021, will incorporate 4 cycles of chemotherapy, 2 cis-containing cycles, 2 carbo-containing cycles, with etoposide, followed by either 18 or 23.4 gray without a boost. Second surgeries will be considered for patients with residual masses. In the European group, the results of CNS GCT2 are pending, but early presentations indicate that the second phase of radiotherapy is likely not necessary if a CR is achieved. Thus, 24 gray will be considered sufficient. In an upcoming UK study, patients will receive monochemotherapy prior to definitive radiotherapy in an attempt to reduce the toxicity associated with systemic therapy, lower cochlea levels of injury, and preserve high-frequency hearing loss. As of yet, the radiotherapy details are not specified. Here, I'd like to briefly highlight ACNS 2321, which will evaluate induction chemotherapy followed by dose-reduced radiotherapy. The radiotherapy field extent will be further modified based on whether the disease extent at diagnosis was localized, metastatic, or ectopic, as is the case with basal ganglia or thalamic germ cell tumors. Contrast the prior North American approach with this planned UK trial, which will dramatically change the induction regimen to one of 2 regimens which should reduce the incidence of subsequent treatment-related toxicity cytotoxicities in this favorable group of patients. 2 response assessments will be utilized to gauge the response to the appropriate number of cycles of chemotherapy, with the second response assessment preceding definitive radiotherapy. Surgery will be an option for patients with residual masses that are greater than 2 centimeters in diameter or with stable disease. The radiotherapy paradigm, i.e. the dosing and fields, have not yet been defined for this trial, but will likely include whole ventricular radiation for patients with localized disease and CSI for patients with metastatic disease. The pathway forward for pure germinoma remains exciting. In fact, it appears that from ACNS-1123 that further radiotherapy dose reduction may be possible, which may mitigate future treatment-related late effects in this patient population with an excellent prognosis. There are still some subtle variations in the induction chemotherapy regimen that is used in international study groups, and the optimal regimen as a result has not been defined, and this will require future cooperation across these study groups. Moving forward, we need to adopt the rigorous imaging baseline and response recommendations put forth by the consensus group report. And at present, the standard of care for metastatic germinoma has not improved in the last 25 plus years, and further approaches should be evaluated in multi-center studies with particular attention on late effect mitigation, given that these patients also have an excellent prognosis. While relapses are uncommon in pure germinoma, these are usually salvageable, and so evaluation of targeted therapies in relapsed pure germinoma will be difficult if not impossible. But one has to wonder if there's a role for replacement of conventional cytotoxic chemotherapy in patients with inadequate radiographic responses during frontline treatment. Specifically, will this result in a reduction of late effects and facilitate comparable disease control? This remains unclear. I'd now like to move to the evolution of multimodality therapy for non-germinomatous germ cell tumors. While a variety of approaches have been employed, I've summarized several key points below. In general, these tumors display a higher responsiveness to chemotherapeutic agents, although chemotherapy alone is insufficient to achieve cure and has been associated with 50+% relapse rate in prior studies. The combination of radiotherapy with platinum-based chemotherapy plays a key role in achieving the optimal outcome and has now become the standard of care in this group of tumors. The largest area of controversy is that of in radiotherapy field choice. While the PSYOP CNS GCT96 and 2 showed us that focal radiotherapy was adequate when paired with appropriate systemic therapy, ACNS-1123 has noted an excess of spinal failures, and as a result, the successor study, ACNS-2021, is now utilizing whole ventricular radiotherapy plus spinal radiotherapy with ACNS-1123 chemotherapy backbone. CSI still remains the standard of care for patients with disseminated disease, and in off-protocol patients, we still use CSI for patients with localized disease. Of note, many trial groups are now reconsidering the use of ventricular radiotherapy. In fact, the next PSYOP study is offering up the potential option for the use of whole ventricular radiotherapy for mixed germ cell tumors with a dominant germinoma component, as these have been noted to have a higher rate of ventricular failure. Given the discrepancies in the risk classification schemes, it remains unclear how much additional benefit more rigorous interventions like high-dose chemotherapy and stem cell support offers for higher-risk germ cell tumors, and this will of course be a subject of further investigation for patients with inadequate responses or high-risk features. This recent analysis by Fonseca et al. Highlights the controversy in radiotherapy field type choice. In this pooled analysis of international trials, they showed that focal or whole ventricular radiotherapy was not associated with an increased risk of distant relapse. Of course, distinctions between the risk for a ventricular or a local failure and radiotherapy field type choice have not been evaluated systematically across trial groups, and this warrants further investigation in order to define who really needs whole ventricular radiotherapy in this disease and who can achieve favorable outcomes with more conformal focal radiotherapy fields alone. Growing teratoma syndrome is a pertinent consideration for patients with mixed germ cell tumors. The incidence is reported to be around 5% and typically occurs with pineal region tumors within 2 months of starting therapy. These frequently require an earlier operative intervention, and the postoperative pathology is typically composed of immature teratoma in roughly half of cases, with 10% of cases composed of a mix of mature teratoma and germinoma. Growing teratoma syndrome is not considered an adverse risk factor, and most patients have a favorable prognosis. North American, Asian, and European trials will likely give us more information on how mixed germ cell tumors will change moving forward. In North America, ACNS 2021 is evaluating only patients with localized disease and has employed the whole ventricular plus spinal canal irradiation volume given the noted spinal failure rate on ACNS 1123. A similar chemotherapy backbone and radiotherapy dosing paradigm has been utilized in this study, although patients with pre-specified criteria will be considered for subsequent high-dose chemotherapy with stem cell transplant, followed by CSI. Asia will be evaluating the role of intrathecal methotrexate for NGGCT based on some historic studies and prior experience with non-CNS germ cell tumors. Because of the discrepancies between the radiotherapy approaches across North America and Europe, the JCCG CNS GCT 2021 study will be evaluating both local and CSI-based radiotherapy approaches. Finally, the role of high-dose chemotherapy and stem cell support will be evaluated given the limited power and sample size on SIOP CNS GCT2. In Europe, we are anxiously awaiting the results of SIOP CNS GCT2. However, we have seen in abstract form some of the results of the localized NGGCT stratum and noted that the localized arm appears inferior relative to SIOP CNS GCT96. Contrast this with the findings that patients with metastatic NGGCT are superior to the prior trial. And finally, the last question of whether or not high-dose chemotherapy with stem cell support for patients with high-risk disease suggests a potential, but not confirmed, improvement in event-free survival given the limited sample size. This approach will require further evaluation and likely systematic review across trial groups to definitively confirm the benefit in high-risk subsets of NGGCT. I'd like to briefly highlight the ongoing COG-NGGCT study, which will employ 6 cycles of chemotherapy followed by a central review of the response. Patients with a CR or PR and normalization of markers will go on to whole ventricular plus spinal radiotherapy to a total dose of 30.6 gray, followed by a boost to 54 gray. Patients with less than a CR/PR will be considered for subsequent second-look surgery and will be risk stratified according to pathologic results. Patients with less than a CR and the shown additional criteria will be considered for both subsequent surgery, and if viable disease remains and or markers haven't normalized, will proceed with high-dose chemotherapy with stem cell support, followed by consolidative CSI to 36 gray and a boost to 54 gray. Contrast the previously noted North American trial with the upcoming JCCG trial, which will compare 2 treatment paradigms, one with cis-cyclo and etoposide-based chemotherapy for 5 cycles, followed by large field radiotherapy with CSI plus a boost. The other arm will receive cis-etoposide cyclophosphamide and intrathecal methotrexate, followed by just local radiotherapy, thus abstaining from large field radiotherapy. If residual tumor is noted in either case, a second-look surgery will be considered. Patients with residual disease or in non-CR will be considered for high-dose chemotherapy with Iatopa and melphalan with stem cell support. So now, in thinking about the appropriate pathway forward for non-germinomatous germ cell tumors, I've summarized some thoughts from the recent literature. To ensure that patients undergo appropriate risk stratification and radiotherapy field choice, we need to adopt rigorous imaging at baseline and response akin to the recommendations by the recent consensus group report. We also need to reconsider risk stratification for non-germinomatous germ cell tumors in future North American trials. We also need to evaluate the potential incorporation of molecular markers for adverse clinical behavior, like gain of 12P in non-germinomatous germ cell tumors. We also need to systematically devise an approach for the evaluation of targeted or precision therapies for the MAP kinase and PI3 kinase pathway and KIT receptor aberrations in the recurrent setting and future relapse studies. This could be potentially paired with a frontline cooperative group trial to ensure that these cases are captured for evaluation of these therapies. Finally, we need to be thinking about how we might employ these targeted precision therapies for pathway aberrant cases and the setting of incomplete response following conventional frontline therapy. In the last few slides, I'd like to contrast the systemic therapy dose exposures across two recent North American trials and CNS GCT2. Please note the varied use of cis and carboplatin and the doses and dose intensities across studies. Please also keep in mind when considering the late effect profile, this subset of favorable brain tumors in a high surviving portion of patients, especially in light of recent studies which indicate that hearing loss can further complicate neurocognitive outcomes in young children following cancer therapies. Thankfully, relapse remains rare for pure germinoma and only occurs in 20 to 30% of patients with non-germinomatous germ cell tumors. This makes late effects programs vital to improving the long-term quality of care for survivors of this spectrum of diseases. Standardized late effects surveillance guidelines are sorely needed to assess organ function, facilitate optimal achievement, and optimize their potential quality of life. The domain of these required evaluations are listed below, but the precise schedule and type of evaluation have not been rigorously standardized. In conclusion, I hope I've shown you that multimodality care has undergone a substantial evolution, which has resulted in improved outcomes as well as an improved understanding of the disease. But the pathway forward requires that cross-disciplinary and international collaborations be conducted to find the optimal pathway forward for patients with non-germinomatous germ cell tumors and pure germinoma. Before we can integrate the next phase of therapies into the frontline treatment of this disease, well-designed relapse studies are needed to define the therapeutic potential of targeted agents before they are broadly incorporated. Finally, late effect programs remain vital to improving the long-term quality of care for survivors of this spectrum of diseases. In the last few moments, I'd just like to say thank you from the team at St. Jude for the opportunity to discuss this topic, and I welcome any question.
Thank you very much, Dr. John. It's a very lot of information we can get from your talk. So we can open the discussion, Dr. John.
Yeah, thanks so much for the opportunity to talk. It was a lot of fun seeing what some of the most recent developments are as far as the I guess innovations for this subset of tumors. I was at SIOP 2 weeks ago in Ottawa, and there was a really nice update from every clinical trial group, which kind of gave some of the updates and showed some of these updated schema, which I feel like make this even more interesting, as a couple groups are really trying to push the envelope and change up the paradigm relative to what's been done for the past 2 or 3 decades.
Yes. Okay. So we can open discussion. So is there any from participants would like to ask directly to Dr. Lucas? Actually, for this is not for the treatment, but the preparation of the patients that all the germ cell tumor patients needs to have both CSF and serum tumor marker, as well as spine MRI. What do you think?
Yeah, no, I totally agree. And I think, you know, historically, germ cell tumors have been one of the few CNS tumors where many would not necessarily consider a biopsy mandatory, but I think more and more individuals are considering that. There's a huge divergence of, I guess, estimates as to what proportion of cases like bifocals are mixed versus pure. It was it's been interesting to see some of the papers come out. I've seen numbers as low as only, 3 to 6% are going to be mixed, and then other situations or other papers which have put that number all the way up at 1 in 3 could be a mixed germ cell tumor. But in terms of kind of baseline staging and evaluation, yeah, I totally agree. And I think, historically endoscopy also played a role for staging as well. So in inspecting the ventricular surfaces and seeing whether or not they were studding. And, we don't make that a part of our staging criteria, but, a lot of these patients will get an ETV, and they'll punch a hole in the floor of the third ventricle. And during that, I think the surgical team gets a unique window into how extensive the disease is, as sometimes I think some of the ventricular seeding may not be as readily apparent by imaging. I think it's going to be really beneficial moving forward to have more systematic imaging done. There was a recent manuscript which is really tried to push for rigorous imaging for both the brain and the spine. That was at least one potential explanation for why on the last North American study there was an excess of spinal failure rates. I would argue that good spine MRIs are quite hard to find in the community. And we get a lot of tertiary referrals from all over the U.S., other locations in North America, and then internationally. And one of the most common things that we do before we even make any comments about whether or not a patient's localized or metastatic is we repeat our own imaging. And our diagnostic imaging team has the spine MRIs just absolutely dialed in. They're phenomenal. So I think having that codified in the guide, like what I mentioned in Moreno, will be great, and hopefully that'll be incorporated in as many future studies as possible.
Yeah, and the problem here in Indonesia, not all the hospital has the opportunity to have MRI. They only have CT scan. Yeah, there is the neurosurgeon, there is a pathology, but there is not MRI imaging, and just only CT scan. And then sometimes if we would like to do imaging on spine with CT scan, it took like several weeks to queuing for the additional imaging of spine. So what do you think this condition? I mean, this is not an ideal condition to treat germ cell tumor without the imaging on the spine as well as the CSF for tumor marker. What do you think about this?
Well, I think it depends on what paradigm you're going to go down as far as treatment. So if you have a pure germinoma, you've confirmed that it's just a modest elevation at beta HCG, and then a negative AFP. And let's say you can't get a good quality spine and brain MR. Remember, CSI is curative without doing any chemotherapy, and that's why the last couple of CNS GCT studies have allowed for patients who are incompletely staged to be treated with a CSI-based approach. And so, I think with limited resources, sometimes that's the best thing to do. If you either can't complete out the staging or the delivery of chemotherapy could be complicated. And, for patients with diabetes insipidus, sometimes it could be hard to give, platinum-based drugs as well. And so that can make things challenging. So there's some situations where just proceeding with definitive radiotherapy could be beneficial and maybe make up for that lack of staging. I think it's harder with mixed germ cell tumors because you have you need chemotherapy. The radiotherapy field off protocol for many groups is still CSI, and that's what we generally recommend in North America. But but if you have one of those patients who develops growing teratoma syndrome, that tumor could get quite large before they get symptomatic. And so if you're not able to do those regular imaging response evaluations by MR, it could be a challenging situation for the child, and it could result in a potentially morbid surgical intervention just to mitigate that known issue associated with the natural history and treatment of mixed germ cell tumors.
Right.
So that's tough. I mean, I guess if it was a substantial change in size, you would pick that up with a CT. But that's, I guess, one situation where not having, I guess, rigorous imaging would maybe be to the detriment of the patient.
Right. Thank you. So we have a question from in the chat box. You can see also from the chat box, right? There is a question from our resident, Dr. Khalid. So yeah, based on ANO consensus from intracranial GCT.
Yeah, so this is a great question. So if the question is if initially there's no spinal involvement, so this is a localized germ cell tumor that's had a favorable response with neoadjuvant chemotherapy, is it appropriate to do whole vent, or should you just do CSI if there's a situation where we don't have a spine MRI to prove spinal metastases? Yeah, so this is just like the situation that we were just talking about. Incompletely staged patients, at least on, I'm fairly sure the last two studies have allowed you to do CSI in the absence of good staging. And I think that's a reasonable thing to do. In the last study, there might be a little bit more language about whether or not to do CSI or not, but I think that's a perfectly reasonable high curability approach for that situation. And then the next part of it says, in contrast, some cases with proof of no spinal metastasis from MRI and LP, there are cases of spine failure. Should CSI be considered? So again, talking about a pure germinoma, yes, it's certainly possible to have a spinal failure. They're rare, they're uncommon. In North America, the recent area that has been discussed is whether or not to cover the biopsy tract. We've seen, I've actually seen a few cases here in our practice where a patient had an endoscopic procedure to biopsy either the pineal or the suprasellar mass. It was a transcallosal approach, and then in the process of, I guess, pulling back out, there was some seeding of the tract, and you could see some, and then there was a delay between that biopsy and subsequent radiotherapy or subsequent initiation of chemotherapy. And so we saw some growth or studding along that tract. So that's a tough situation. This is where chemotherapy also helps us out. I think it probably reduces that spinal failure rate. And so combined modality therapy maybe makes up for a lack of, very high sensitivity MRI and LP across lots of community centers. And then the last part of the question is, how is the fractionation schedules of these, how are they different? And that's a great question as well, because you see a lot more variation in the fractionation schemes for germ cell tumors than you would for, say, most other either gliomas or embryonal tumors. And fraction sizes in the 1.5 to 1.6 gray range are frequently utilized. And given that we've had a successive, we've had multiple studies which have documented lower doses are required for especially pure germinoma, it's required that we kind of change up our fractions to kind of make things work out practically. I know with whenever I'm treating a pure germinoma and it's a disseminated case, I'll use 1.6 gray per fraction just because the math works out a little bit better for the CSI in the subsequent phase. I think it's perfectly okay to vary that up between 1.5 to 1.6, but in general, I recommend that whatever flavor of therapy, whatever treatment paradigm you're using, try and follow that as close as you can, because you don't want to add any additional heterogeneity into the picture that may compromise the outcome. Although, you know, the difference between a 1.5 gray fraction and 1.8 gray fraction, I think, are minimal, especially with cases that have such a high curative potential.
Thank you. So there is another question from residents, from Dr. Lucy, second-year resident oncology resident from Indonesia. There are two questions she would like to ask. Maybe Dr. Lucy would like to.
Oh yeah. Okay. Sir. Thank you so much, Dr. John. So I would like. So my name is Lucy. I'm a second-year radiation oncology from Indonesia. If I'm allowed, I would like to ask you two questions. For the first question is, in a case of potentially a tumor containing both germinoma and teratoma, like how can the diagnostic process be optimized to accurately identify whether a tumor is solely a germinoma or just teratoma, especially when the case where a biopsy only just like maybe like half of them or just less than 20% of the tumor is just being removed, and there is a risk of inadequate tumor removal during the surgery instead of complete debulking. So maybe that's my first question. Maybe just one by one or just. Okay.
Oh yeah, I can address that one first. So remember, if it's a mature teratoma, you would still treat with the germinoma paradigm, and that's probably the only situation where a subsequent look surgery is beneficial for pure germinoma, where you have a residual mass, and you have to prove to yourself that it's not either a incorrect diagnosis, and to prove that all that you have left is that mature component. And if there is a mature component, most protocols will still allow you to use the more favorable profile, meaning you're documenting essentially that they're meeting the required radiographic and clinical response criteria. So further dose de-escalation is okay. Now, if you have an immature component, then obviously you need to be using a mixed germ cell tumor paradigm. And you really need to be giving that patient the whole 9 yards. They need to be getting 6 cycles of usually a platinum-based therapy, plus minus ifosfamide and etoposide, and then usually those cases should get CSI, and there's a much bigger role for surgery in general. And then if there was any viable tumor at the time of subsequent look surgery and it was an immature teratoma component, a lot of those patients will go on to receive aggressive therapy, and the most recent mixed germ cell tumor studies are recommending high-dose chemotherapy with stem cell support followed by consolidative CSI. And that's based on some early results from CNS GCT2 that's come out in abstract form, which shows a modest improvement in progression-free survival, but it didn't meet the statistical significance threshold that they pre-specified the study, just because they didn't have high enough numbers. And that was predominantly just in the high-risk subset. So the JCCG CNS GCT 2021 study is going to be using transplant in a larger population of patients who were not, I shouldn't say a larger population of patients, but patients who have an inadequate response, meaning they haven't normalized their markers, they haven't had a sufficient radiographic response, et cetera. And so we'll get a little bit more information on where the role is for that type of therapy. And then your subsequent question, it says, is it feasible for growing teratoma syndrome to manifest in the pineal region with a teratoma, considering its rarity? What are the mechanisms underlying the initiation of this syndrome in such cases? Yeah, that's a great question. And, you know, as far as the pathophys and the mechanisms, I can't speak too much to it. I've read some people attribute that to kind of a differentiation process. So I guess treating the less mature elements all you're left with is tumor that is now differentiating into the more mature component, and then that stimulates a kind of proliferative response. That's a very hand-wavy understanding. It's really not clear, and I think it's fascinating. And it's also really problematic too, right? Sometimes from a practical standpoint and a treatment delivery standpoint, because I've seen some patients get quite symptomatic. And I think overall, once you have a diagnosis, I think it is better usually to wait for a nice systemic response to systemic therapy for most germ cell tumors, because then the surgery is generally less morbid, but there's that small percent with growing teratoma syndrome that it could be a potentially more morbid surgery, and so that's hard.
So how can you evaluate, like, do you have any recommendations, like maybe within during what time of we can evaluate the suspicion of the growing teratoma?
Yeah, so I think there are some general rules. So most cases are going to occur at about a median of 2 months into therapy. So that's going to be right around 2 cycles in. So that's helpful. So if you have some new symptom, especially for a pineal region case, right? So if their paranoids gets worse, they have worse upward gaze, they have more nausea, more headaches, increased sensitivity to light, papilledema, all of those things confirm that, hey, there's something else going on. And so maybe it's time to get some additional imaging at an earlier time interval. And so I think doing, symptom-based or symptom-initiated imaging assessment, independent of whatever protocol, would require as far as imaging assessment, is the right thing to do.
All right, thank you so much.
Yeah, absolutely. Great question.
So we have another question from the chat box from Dr. Nico from Dermis Cancer Center. He would like to ask about the recurrent pure germinoma within radiation, whole ventricle irradiation veiled in just 1 year. Do you have any suggestion what to do with this patient and if you decide to irradiate?
Yeah, that's a great question as well. There are a couple retreatment studies that are out there. I did mention one prospective phase 2, which is going to be evaluating the therapeutic utility of a KIT inhibitor, avapritinib. That'll be through its PNOC 032. That study is combining a targeted agent, and then also allows for consolidative radiotherapy depending on response. And then I believe there's also a transplant component. I don't remember the schema entirely. I think it's always best to put recurrent patients on a clinical trial if one's available, although recurrent germ cell tumors are really rare, right? And so they're kind of a victim of their own success in that regard. So that's why I think it's exciting to enroll on studies like that PNOC study, because it's really going to give you an opportunity to learn about an entirely different class of therapies that have not been evaluated in these in this patient population at all. So can you re-irradiate if the trial's not available or there's no other great options? Yeah, absolutely. Although, at 1 year out, I'd want to systematically restage that patient. I want to do an MRI brain and spine. I'd repeat serum and CSF markers. I'd like to just absolutely confirm that it's not a mixed germ cell tumor, and that for some reason there wasn't a misdiagnosis on the front end. I wouldn't employ like a high-dose chemo stem cell rescue approach. I would reserve that for a relapse mixed germ cell tumor. I think, if you have a patient that recurs, they were initially a pure germinoma and they recur pure germinoma, I think that patient still has some curative potential. And so I think the radiotherapy field design and what total dose you go to, et cetera, should be somewhat individualized based on the type of case. And so I can't give you kind of a full systematic recommendation. Recurrent brain tumors in general oftentimes require somewhat of a customized approach to kind of dance that delicate that balance, or thread the needle essentially of providing the max curative potential and also minimizing the risk of harm. But thankfully, the doses are low enough with pure germinoma where a second course of radiotherapy usually isn't a problem.
Great. Thank you. Dr. Nico, is it okay? Or you want to ask directly? Okay.
No, thank you, Dr. Bobby. All clear.
Okay, thank you. So is there any question from the audience? I would like to ask, this is a very, what is this, basic questions. I'm a lot of a doctor also would like to ask the same things, like how about the pure germinoma, based from the pathology findings, pure germinoma, post cranial removal, but maybe not the growth. There are still residual tumor after the craniotomy. So for the pure germinoma, the patient only have imaging of post brain and then post imaging for the spine, but without any CSF or serum tumor marker. So regarding these situations, for the radiation, would it can be given whole brain irradiation plus boost, or we can go directly to the whole ventricle irradiation plus boost? What do you think?
So we're in the setting of, so we have residual disease.
Yes, residual disease.
After chemotherapy, and there's
no chemotherapy. It is a pure germ.
Oh, no, pure germinoma, and then, okay. So, and you said we don't have markers. We do have spine imaging, but there's no spinal disease. So it's a localized pure germinoma. And the question is it okay to do whole vent, or should you do whole brain? Is that the question?
Yes, or maybe just give CSI and then boost.
Yeah, so that's a great question. So ACNS 0232 tried to answer this question of whether or not whole vent alone was enough for this situation. And unfortunately, it failed to accrue. And it probably didn't accrue for a couple of reasons. One, North America germ cell tumors are less common. So that's one reason. Two, I think some individuals didn't want to randomized. Some individuals wanted to they had the inherent bias of, well, we should try and dose reduce the radiation and instead give some chemotherapy to facilitate that. So I wish we had those study results. I wish that study accrued so we would have a better answer to this question. But historically, I don't think that's an unreasonable approach. And so I think if it was my patient and I was making that type of decision, in our center, we use proton therapy. So for me, doing CSI definitively to 24 gray in an adolescent or young adult, that has a fairly favorable long-term toxicity profile, short-term, long-term toxicity profile. And then you have essentially a less than 5% risk of it ever coming back. So I love that insurance policy. And to me, it doesn't, dramatically differ from like a photon whole vent plan in terms of what that morbidity profile looks like. So I'd probably err on the side of offering that added field so that the patient feels more comfortable about their disease control, and just not play the risk category, because I don't have the evidence to say what that spine failure rate is going to be with whole vent alone, beyond just using retrospective studies. But there's plenty of retrospective data that where people have done whole vent radiotherapy alone and not seen a substantial risk profile associated with it. I can't give you an exact number because that number's all over the map depending on the site, the numbers, how good the rest of the staging evaluation was, et cetera.
Okay. Thank you. Is there a question from the floor?
All great questions. This is good discussion.
Yeah, because nowadays the collaboration between a pediatric medical oncologist and the radiologist and radiation oncologist as well as the neurosurgeons now is getting intense. I mean, like in the previous time, like several years ago, we treat separately, but now, because of the discussion at the tumor board, so we can like, oh, this is non-germ, so we can proceed the chemotherapy first, and then after that we are prepared to give like a CSI and etc. etc. But the problem is for the second look surgery is not that easy because the condition of the patient sometimes not easy, or because of the waiting list of the operation room. So the second look surgery is less likely to be done in here.
And I think in most contexts for pure germinoma, that's okay, right? The utility, the real role for a second look surgery in germinoma, it's a very small percentage that probably need it. And for me, it's just I would want to get one if you have, greater than 1 centimeter to 2 centimeter pineal residual mass after systemic therapy. I think those kinds of cases with after systemic therapy, it probably means they have a mature teratoma component. The optimal treatment for that situation is to remove that because radiotherapy is not not going to definitively cure a patient with mature teratoma. So but it'll take care of the germinoma component. So I think it's always harder to kind of coordinate systemic therapy, radiotherapy, and surgery. And more communication is always better. I think regardless of whether or not we're talking about germ cell tumors or other tumors, I think it's always great to have your friends on speed dial from other specialties.
Yeah, right. So I would like to call my colleagues. Is there any question? Usually Dr. Elia or Dr. Eko, would you like to ask some question, or Dr. Handoko, or would you like to share my experience? Dr. Elia or Dr. Eko or Dr. Handoko? Okay. Or oh yeah. So yes, since we have no more questions, I think, so we can conclude these discussion sessions for the CNS germ cell tumor. I would like officially thank you for Dr. John, your great talk and then experience, and you have given a very nice presentation for us here for Indonesian Radiation Oncology Society, especially the subspecialty of pediatric interest. Hopefully from your talk we can improve here the treatment of a pediatric cancer patient, especially for the CNS germ cell tumor. And I thank you for your time, Dr. John. It is already night over there, right? So
yeah.
So hopefully if there any opportunity, we'd like to visit again St. Jude at same as last time. We went there. It's very nice, very comprehensive treatment of all research as all study patients there, Dr. John, right?
Yes. Yeah, you're always welcome. Just let me know ahead of time. Happy to take you on a tour.
Okay, everybody, I will close the session. Good morning and then good night to everyone. Thank you very much for joining this mini lecture from Dr. John Lucas. Thank you, everyone. See you again. Bye-bye. Thank you, Dr. John.
Bye now.
Bye.